Now, I just want to touch on brief advice. This has sort of been a bit of a nuisance, this whole brief advice thing, because we all give brief advice. I don't think anyone here would ever now ask someone if they smoke, and the person says, yes, I smoke, and you go, good. It just doesn't happen. You're going to do this as part of your everyday practice, and you've probably been doing it for years and years and years. When it comes to recording brief advice, it's a bit of a strange thing to do. We give advice on lots of things all of the time, and recording it is not really quite what we do. And I really want to emphasise that it's really, we've got to focus on the clinical outcomes of this whole ABC pathway. And by that I mean, if you make an offer of treatment and someone accepts it, then you make the referral or you do whatever that they want to accept. And if they decline, then you can say I offered but they declined. So it's less about documenting brief advice and more documenting the outcome of the intervention itself. And I'm going to leave that to John to talk more about. But the evidence behind brief advice is still the same. It's still, the main effect is by prompting people to give quitting a go. It does increase long-term quit rates, small, but on a population level, 3 percentage points is pretty good. And if you want a number needed to treat, it's around about 33. It depends on the baseline or background quit rate. Now I'm just going to show you a number of slides from Robert West's Smoking Toolkit study. Now this is an ongoing study, it's longitudinal, and they follow up a cohort of people who smoke and don't smoke over time. And advice from healthcare professionals are still the key external driver to making a quit attempt. What you say is incredibly important. And I know you'll have people come back and they've stopped, not stopped, and you think, why do I even bother? But it's important to keep on bothering and keep on doing this. And it's the offer of support that's important. So again, these data from the Smoking Toolkit study, and you can see there the only intervention that's effective in prompting quit attempts here, above the background quit rate, i.e. that in those that didn't see a GP, is the offer of help to quit. And this is where the new guidelines or the revised guidelines have changed, and it's more a focus on make an offer of treatment as opposed to just give brief advice to stop smoking. Okay, so this is the sort of new emphasis is I'd like to help you stop, or there are different ways, or I've had patients that have stopped smoking using this particular service. Would you like to give it a go? So hopefully a little bit more clinically focused than just brief advice.
And essentially we know that there's kind of 3 things that are necessary to encourage GPs and practice nurses to engage in offering brief advice, offering support to help people stop, and yielding an outcome with cessation. And the first one is that actually needs some kind of reminder to make sure that it's going to happen. So there's several different kind of reminder systems. These are reminders that come up on the clinical notes when you have a patient in front of you. The one on the left-hand side there, that's a dashboard reminder, and what it will show you is if the person hasn't been asked about smoking, it'll be red, and it's a prompt that says, yes, please engage with smoking cessation with this person, and reminding them. The one on the right is the patient prompt. Most areas in the country will have one of these kinds of reminder systems, and if they haven't got one, they definitely need one. It's very difficult to remember to add this into the already busy space of general practice without some kind of reminder. The second thing is that there's another population another way of looking at the population of people that come into general practice. There's those that come in, and obviously we're going to engage in the consultation room, but then there's the population that come in any one day. And what we know is that it's possible to use a tool like an appointment scanner that will go through your list of appointments for the day and tell you these are all the people that are coming in who are smokers with whom you might like to engage. And that means that where there is difficulty with remembering or being able to fit it into the consultation, we have other options. So for example, a practice can look at the appointment scanner and say, today we have 4 smokers coming in to see John McMenamin. John's going to deal with 2 of them, but the practice nurse is going to deal with the other 2. So there are ways of actually addressing the needs of people who are differently coming in to see us both in the consulting room and in a planned way. And the third one is that we need to be thinking about the third population, and that's the population of people that are not coming into the practice. So how do we know who those people are? We know who they are if we actually code all the smoking consultations. So the reason for coding consultations, and this is what we need to be sharing with primary care practitioners, with GPs and practice nurses, is not just that it actually helps that individual person's record so you know that they've actually had the advice, but that you can identify who hasn't been asked. And then you can use your audit tools, and there's different kinds of audit tools out there that will identify, for example, who hasn't been asked, and then those are the people that can be contacted.